Good, how are you?
Good.
I'm great. Happy Monday, everyone. So excited to be talking about all of the topics. Melasma. I want to thank everyone that has sent in their questions. We've got some wonderful tonight, and I do want to say that I'd love for you all to share with me. For me in my practice, I feel like melasma is one of those things that it gives patients so much psychological distress as well. Do you all find that, and how do you handle that?
Oh, yes.
Yeah.
I think the physical aspect of melasma can be equal to the mental aspect of melasma. I mean, people come in and they are so distraught, they don't want to leave their house. Don't you find that?
Yeah. One of the problems is that it's a moving target. It's always evolving. It's changing depending on the time of the year, the amount of sun maybe they've gotten exposure to, whether they have an inflammatory component to it. So it can look different from day to day, even when it's in the same place. So that can be very disconcerting.
I think that these are all wonderful points, and I actually want us to define melasma and who gets it, because I think unfortunately there are a lot of times when people that have hyperpigmentation due to different causes, like for example, when someone has had acne and they're left with the post-inflammatory hyperpigmentation marks, they come in saying, "Doc, I have these spots, I have melasma." And so that's not accurate. And so I think for the dermatologists in the group, they would know this, but for the public that's joined us this evening, I'd love for you all to share, when someone comes in, what is your definition of melasma?
I'll take that and I'm going to tell you who gets melasma.
Well, I think that the definition is broad because it can present itself in so many ways, but we generally think of it as a disorder of pigmentation, and a disorder of pigmentation, and that it can affect women disproportionately than men. It tends to happen, in the third and fourth decades, usually. Men can get it, but it's rare. It tends to be in photo-exposed areas, more so than any other place on the body. So disproportionately, I think you'll see it on the face, but you can also see it on the neck. And we all know about how it can be on the inner arms of some people as a response to heat. But that's not the most common presentation. So a disorder of pigmentation, primarily affecting adult women. It can also have a vascular component, and it can be in poorly defined areas on the medial aspect or the cheeks. It can be on the temporal sides, the jawline. It can be right above the lip. Disproportionately seen when women get melasma in response to oral contraceptives. It can be right above the eyebrows. It can be smack dab. I know Diane's had a patient with it like literally right in the middle of her forehead.
Not anymore. We'll get to that point.
Yeah. So different. And then as a dermatologist, we can bring in a Woods lamp. It's a special light that can help guide us, because usually that pigmentation in melasma is going to be more abundant in the epidermis as opposed to the dermis, which can differentiate it from post-inflammatory hyperpigmentation that you might have had from acne or a mosquito bite. Although you can have melasma that does drop down deeper, but usually you're going to see the majority of that pigment and by Wood's light in the upper part of the skin.
So I'm going to add that there are really, especially according to Dr. Shireen Idris, who is, I think, amazing and has talked about this on her YouTube videos, there really are 3 different types of hyperpigmentation. So, one is the post-inflammatory hyperpigmentation, another is melasma, and then you have just little small freckle spots, lentigos, whatever you want to call them, sunspots. But melasma seems to be the most difficult to get rid of, because it can be, like Dr. Simmons-O'Brien said, it can be epidermal or dermal, but it kind of always comes back. I mean, you turn your back for a second and you don't protect your skin, and then it comes back. And it can be in any color skin. I don't care if you're super fair, super dark, it could be in anybody. It is more prominent, I think, in the darker skin types, Middle Eastern people, Indian, Asian, but you certainly can have it in lighter skin.
Yeah, and I think that's a good point too, because again, we get hung up in skin types in dermatology, which my personal skin types go to type 7.
Wendy Roberts classification.
Exactly. So plug for Wendy,
Yep.
where I think it's super important to ask people, what is your ethnicity? What is your race? You might have someone who appears to be fair skinned. So let's just say a type 2 complected person, but that person could have, a Black parent, that could have a Middle Eastern parent.
Or the Black Irish.
Yeah.
I had a patient tell me that she was Black Irish.
Yeah. So you need to know what the ethnicity is, how they heal. Like when you get injured, how does your skin heal? Do you have marks after you cut yourself, or you have some sort of minor injury? I mean, I think all of those questions are super important. You just can't presume by looking at a skin type.
I couldn't agree with you more. So on my intake form, and I have some patients ask me, why are you asking me that? I always ask, and I never assume, no matter how fair you are, no matter how dark you are, where I think you're from, I want to know specifically, where are your genes from? Who's your mom?
Smart. Very smart.
Ancestry. Why? Because you can have, here in Texas, I have a very fair, blonde-haired, blue-eyed person that had American Indian descent. She had gone somewhere, was treated with IPL, because walking in the doors, yeah, you would think she'd be a great. Unfortunately, had horrible IPL burns. And you're right. You can have within, I call them the Mediterranean zone, and I'm part of that zone as a Persian girl. Very respectful of pigment. And I always say, I don't care if you're light skinned and olivey, if you are Iranian, Greek, Italian, Indian, any of the African American of any color, light, dark, I don't care. Respect your pigment. And we are going to do a test spot if we're going to do whether a product, a peel, and laser. And that's the other thing. I think there's so many myths out there. I think one of the biggest pearls to share with patients is setting up expectations. When they first come through the doors, I let them know this is going to be a long-term.
Absolutely.
We call it the long game. Like when I'm down love 40 playing tennis and my serve, I say to my partner, it's the long game. So we're not going to give up, even though the score looks pretty damn bad at that point. That's my code lingo. It's the long game. And you're absolutely right. It's a process. It's a journey.
People will say, how long do I have to do this for? I'm like, forever. If you want to have your skin tone even, it's forever.
That's the important.
It's sad.
That I think as board certified dermatologists, we are always honest with our patients.
Yes.
Why? And I think setting the expectations early so they know, because I had someone knowing that we're doing this today send me a DM, doc, I got all these creams, I'm so upset. Can you laser this off of me? And I wrote back,
let's talk about that.
Yeah.
Let's talk about laser and melasma.
That I do is going to be individualized for you. If your friend did a particular product peel, it doesn't mean that it's going to work for you. And that's in this generation where we do have Instagram, we've got TikTok, we've got so many things out there. I'm so happy that 3 board certified derms are here this evening discussing, because we know the reality. We don't want to do procedures that are not going to work for you. For example, lasers, let's talk about it. In my practice, those are way back over here when we're talking about melasma.
Right. I've had people where I've used the laser. This was actually years ago when we were told, oh yeah, use laser for melasma. It's worsened it. And I ended up doing, going back to my chemical peels for the patient or microneedling with or without PRP. We find that that's much better treatment than laser in our hands in all skin colors, really.
Yeah, that's been a godsend. The skin pin microneedling, I love it. I prefer to do it with PRP, purified refined
Me
plasma.
too now. It takes me a while to adapt to what even says.
But my mouth was hanging open.
Yes.
I was astonished
Absolutely.
at how well it really worked for melasma. So I do not at all use lasers for melasma. I agree with Dr. DJO here. I made someone worse with the laser, and I was like, oh golly, now you got to kind of backpedal. But you have to also let patients know it's not a one and done. It is a village. It is an entire village to take care of this problem.
When you guys needle, what depth are you doing and how many sessions do you recommend? Given that the treatment is more superficial, are you at like a 0.5 to a 1?
So it's different for different parts of the face. So I tend to do, and it depends on how thin someone's skin is. On the forehead, I tend to do 0.25 to 0.5. In the eyebrows, I do 0.25. Under the eyes, I do 0.25. On the cheeks, if I'm extremely aggressive, I'll do 1.5. If some people can only tolerate like 1.0, they're bleeding, you could see that they're going to have petechiae and it's going to be a mess. So I might stay at 1. Around the mouth, again, it depends on the person. I might do anywhere between 0.5 and 1.0. On the nose, I can get away with like 1.0 because it's more porous. And then on the neck and jawline, I tend to be about a 1. Unless I have super thick skin, I might do a 1.5.
Yeah, I'm pretty much the same, but I do a fair amount of microneedling on skin types 4, 5, and 6.
She does more than I do.
So for those patients, especially if they've never had it before, I will tend to be less aggressive because I discovered with my darker complected patients and with myself, you actually peel, you hyperpigment transiently for a few days. And I tell them, don't get worried, don't get alarmed, especially if they've never had it before and maybe say that they're not exceptionally what we call peeled down. They might get a little bit darker and then that skin breaks up and they peel and then they get lighter. So I think the more aggressive you are with the depth of the needle, the more likely you are to have that transient hyperpigmentation. And if it's a first-time patient, I'm not going to do that because I want them to feel confident and that I know what I'm doing and comfortable and just set, like you were saying, Elizabeth, setting the right expectation. So I might back down on that depth a little bit.
Can I put a little plug in for board certified dermatologists? I think that, you know, when you're watching on Instagram, oh, look how much they're bleeding from this vampire facelift. Am I supposed, you know, people might freak out if they see that. But I think that we as board certified dermatologists don't do that much intensity on the microneedling because we know that if you're going crazy on the depth and they're bleeding all over the place, you're actually creating more inflammation and you can make somebody worse. You can give them post-inflammatory hyperpigmentation and you can make their melasma worse. So at least I know the two of us tend to not go nuts when it comes to
and that's why I like PRP. My God, if
right.
you,
you don't
need
need to go crazy on your microneedling.
You don't need to make them super bloody. You've got your plasma right
I don't
there.
need to look like Kim Kardashian with that. Yeah, it's just
it's
problematic.
I'm very conservative, especially for the first timers and especially if they've tried multiple things. There's a lot of baseline inflammation, I feel sometimes, in skin barrier disruption to begin with. So I'm starting off at between 0.5 to 0.75 on the cheek area. On the forehead, I feel like I can go up to a 1 depending on what they're neck, again, and I'm talking about people with thicker skin. If they have thinner skin, obviously I dial it down. And then the other thing is, do you all, so I do a little pre-treatment regimen before we're going to do anything procedural, whether I'm going to peel or whether I'm going to needle. And I agree with you. Needling is a godsend, and in the beginning it is a little bit counterintuitive because you are creating an inflammatory response. But I do think with the particular growth factors that are released, that in addition to all the TGF betas and all the other great things that we have as part of therapy, I think that combination is a series of about 3 to 6, depending, but they still have to have maintenance. So what your pre-treatment protocol? And then I'll share mine with you both as well.
Well, this is when we can talk about ourself products.
Not as in we're egotistic. But.
No, no, the product line called Ourself.
OURSELF.
Yes, they have a wonderful cream and lotion that the topical product is called the Dark Spot Intercept, or DSI. And then they have a renewal cream, and they have it in a regular and an extra rich. But those are products that are perfect for pre-treatment if they're used twice a day for 2 weeks.
Can you repeat again who the manufacturer was? I missed that.
Ourself.
It's called Ourself. OURSELF.
Okay, wait. Full disclosure, though, we are their medical consultants.
Yes, we are their medical advisors.
Yes.
Okay.
But we have never done this before, and we really have to believe in something, and we believe 1000% in these products. We did studies on their products in every color skin, and rosacea patients,
type 1 to 7,
eczema patients, and the results are spectacular. So the DSI, or the Dark Spot Intercept, pre-treatment and kind of forever treatment for darkness on the skin, on even skin tone, it is something that can be used.
Active ingredient in it, or what is the active? Is it a hydroquinone based product?
No.
So there's no hydroquinone. So it's their delivery system.
The delivery system is
Proprietary.
it's proprietary, but it's very smart. It's like what they talk about, intelligent peptides that directly target where in the skin the product needs to be.
Resorcinol,
there's
vitamin
resorcinol,
C,
niacinamide. In their peel system, they have tranexamic acid, they have phytic acid, vitamin C,
13.6% TCA.
Yeah.
Now,
But in talking specifically about the pre-treatment, their topicals I really think are amazing and better than anything else I've ever seen that works in such a short period of time.
And there's no halo effect. There's no photosensitivity. I have not seen anybody have any irritation from it. Not that can't happen. Of course it can happen.
now,
But their products are amazing.
what were you guys using for your pre-treatment? Before you had this, what would you use typically?
Cysteamine and tretinoin.
Yeah, absolutely. Cispera or cysteamine, and retinols and tretinoin.
Vitamin C. Everyone would have
vitamin C, but vitamins, I have found it all depends on the vitamin C, and some of the best ones can be irritating.
Yes.
So
you can tolerate. Some people can't tolerate.
My favorite are the Isden Flavo C or the Photozyme C&E. I have found
like the Revision C.
And the Revision C. Revision C is really great for people who have sensitive skin, but there are some C's that are downright irritating.
Right. No, we all know.
And then you're backpedaling, right? Because you're trying to take care of people who already have, pigmentation, based on inflammation.
I find 15% azelaic acid gel is very good too if someone has acne.
Do you like that? I like to use that in the morning as part of the treatment, and then do their either hydroquinone or their topicals for the evening, their tretinoin. Now we have a question: how can we prevent melasma, and how can we maintain the improvement achieved? And so I will say, and I know you guys are going to echo this as well, the number one prevention, if you can't do all these things that we're talking about, and I really mean this, is sunscreen. I tell people
100%.
whether drugstore bought sunscreen, one bought in our practice, any sunscreen that is broad spectrum, when we say these words as dermatologists, we're talking about UVA, UVB, and yes, I do like higher numbers, and I give permission to different formulations for face versus body. Whatever you can get on and consistently use and reapply, this much. It's a shot glass.
Mm-hmm.
So everyone, I think one of the biggest questions is how much do you need to apply to get what's on that? This much, guys. None of us use
Shot
that.
glass.
Really honest. And so I think it's really critical to share that message. And the unfortunate thing I'm finding more and more with all the education that we have, for those patients with melasma, I tell them, we're going to get you better, but it's like weight loss. If you've lost 30 pounds, the diet has to stay, the exercise, the good sleep hygiene, drinking all your water. I said you can't go completely off track, otherwise you'll gain your 30 pounds back. I feel melasma is similar. How do you your patients on this maintenance part? Because it's a lifelong commitment.
Yes, it is. It's just it's a I say it's something you actively have to maintain. It's a battle, and you just have to be armored and suit up and accept it, and and then you'll do fine. I mean, I still find it hard to convince a lot of my patients, especially patients of color, that sun protection needs to be worn daily, every day, whether you're inside or outside, because we now know that blue light,
thanks to COVID, with
or
Zoom,
yes,
Zoom calls,
non-UV irradiation,
yes,
can increase pigmentation and damage to the skin by a different mechanism thought to be an opsonization effect, but it is. And we saw it. We saw people.
Absolutely, phone and computer have killed people's
The
faces
Zoom
during
did
COVID.
people in.
It does.
We definitely saw a lot of change in people's complexion. So again, getting back to every day, whether you're inside or outside, people say, oh, it's just a few minutes outside at the mailbox. Well, a few minutes counts. It all counts. It's
or I
all
just walked the dog at 8 in the morning. Yeah. Well, you're still getting sunlight. So yeah. I have just like Eva, every day I have people. We're like, we're sunscreen dictators.
And SPF treated visors, hats. If you're motivated enough to wear a hat, and many patients are, and that's terrific, or a visor, get one where the sunscreen is built into the material, because they're very accessible these days, very reasonably priced. Many companies have very good quality products that are not expensive. That's your backup. Take HelioCare, your polypodium leukotonis supplement that can help to keep you from getting as burned as you otherwise might. So there, again, it's it seems overused, and I use it a lot, but it is a village approach. It's a lot of different things that all work together.
Absolutely.
That you have to do to maintain it.
The other way too, I think people don't realize that when they're cooking over a hot stove, that heat can increase melasma. So just have to be aware of every aspect of your life if you want to keep this monster in check.
Yeah.
I don't preclude my patients from participating in like hot yoga, spin, other things like that. I tell them it's good, but I do let them know, especially if they have an erythematous component to their melasma, which, and again, that's one of the other things I think people don't realize, that not all melasma is that classic hyperpigmented brown tan. There can be an erythematous component. And so for that, I almost like to do a little bit of combination therapy, almost as if they have rosacea, and
right.
The things that we use for rosacea. And again, critical in that is our sunscreen. I still feel comfortable to provide chemical peels to those patients, but I might go lower in my concentrations and percentages of things and do them like with a bigger interval gap. Do you find the same? I find them to be more sensitive.
Yeah. You can't do higher percentages of TCA on melasma. It just comes back with a vengeance. It might look good at first, but then it comes right back even worse than before.
I agree with it. Yeah, absolutely. I think lower percents and consistency, or frequency of the peel makes more sense than trying to use some very high percentage and then end up with a worsening process.
I agree.
It's a marathon, not a sprint.
I do want to say I have found, and I'd love to hear your vantage point. So for the audience, there's a lot of people that have joined us. I want to share with you, we have two people that are truly experts, not only in pigment, but in all things dermatology. I had the great pleasure of meeting these lovely colleagues and friends at a meeting in New York. They're always lifelong learners. There's always innovating. And so I always think it's so wonderful that we have these opportunities to connect and pick each other's brains, ask questions, and learn. I wish I could teleport to so many of our friends' clinics to see what everyone's doing, because it's so fun to see. One of the things that I found that works, again, I don't have studies or literature, but it does kind of make sense. For those that have erythema, those that have a milder case of the hyperpigmentation, I'm loving putting in an aqua gold, a little bit of neurotoxin, a little bit of PRP, just a very low G prime filler, HA, and stamping them. Again, it's very superficial, but I find that I'm seeing a lightening in the hyperpigmentation as well as a decrease in erythema. And we know that the toxin works through what mechanisms to get rid of the. I can't figure out why it's getting the brown for me. I would love to hear. Have you?
Don't you think it's temporary? I mean, I think it lasts about 4 months. I call it tightening the tablecloth, because I think you have to, fix what's underneath the table first before doing that. And we love that procedure. I mean, I just did it on myself this weekend.
I love it too. We call it the red carpet, kind of the wow factor. But yeah. I agree with you.
Wedding.
It's pretty astonishing how it brightens the skin.
It's a miracle.
Almost immediately. Yeah.
What's your cocktail? Do you guys put PRP or no PRP?
I've done it.
Yeah, I didn't do it on myself this weekend because I couldn't draw my own blood. But if I could draw my own blood, I would have.
I'm very good at drawing my own blood.
Oh my God.
So, but sometimes I'll do PRP. Most of the time I don't do it with PRP, because I do find that the neurotoxin and a little bit of filler, and we also add vitamin C, does wonders.
IV grade specifically.
Yeah, we order that through a pharmacy.
Yes.
Yeah. So like an IV grade vitamin C is what you use?
Yes, and we'll also use IV grade glutathione, and also IV grade TXA.
Amazing. Okay, I'll have to get to that.
We'll send it to you. Right.
Yeah.
I have not done it myself because I haven't gotten my hands on it. I have seen vials of tranexamic acid that our colleagues in plastic surgery use for that. Do you guys have that, and have you ever done any superficial, like a meso-type therapy injection?
Yeah, that's what we do. We put it in the.
Yeah, but we have it made up. We have it made up for us at a compounding pharmacy.
We'll get it to you.
Yeah, the pharmacists have.
Have you found it more effective than some of the topicals that we have?
I mean, like what?
Like, what do you mean?
You mean to add into the alcohol?
And all of the other things like the hydroquinone compounds versus doing this topically.
Oh,
do you, or you use it as
I think it's better. I think it lasts longer.
I think it lasts longer. I don't use. I probably haven't used
hydroquinone.
I don't think I've used it in 4 or 5 years, truthfully.
Unless someone really, really wants it, I don't suggest it. I know it's the gold standard, or has been, but we have other options, and that have been working.
I mean, hydroquinone does not prevent melanogenesis. It just prevents melanocytes from releasing pigment. So guess what? When you stop it, and you do have to stop it,
you have to stop it like every 2 months.
That's where that rebound comes in, and that rebound for some people, not for everyone. It can come rebound with a vengeance, and I have seen that. So it's like those little melanocytes, their cheeks have been getting full with pigment because they are still making pigment. It does not inhibit pigment. It inhibits release of pigment. So when they finally, spit it out, it can be, that rebound can be crazy for some people. And I find people of color look bizarre. They look
gray.
They look like this alien gray. And it's not a natural skin tone.
That's why I remember so sustaining. They did.
So I was using kojic acid. We were fooling around with some other, we have great compounding pharmacists in the state of Maryland, thank God, where we're still allowed to compound.
Capital Compounding, Zach is brilliant.
Yeah. So we really, and they like talking with us, and we just kind of, brainstorm. What can we do? Can we put a little azelaic acid and some kojic and throw some niacinamide in at a certain percent? So we will work with our pharmacists to make compounds for patients, and try them out and see how they work. They'll even do little small tester samples. So, you know, just to see how if it's not, make sure it's not irritating, of course.
Well, that's my comment. I've used some compounding pharmacies and selling a big, you know, 45 grams, and unfortunately, depending on the percentage of the hydroquinone, the kojic acid, the actual combination, some patients are not able to tolerate that.
Correct.
And
Yeah.
diffuse erythema, and it just makes everything a little bit more inflamed.
Right.
Yeah.
And it doesn't happen with cysteamine, and I haven't seen that happen with TXA. What I
Right.
have been doing though is after microneedling, if I'm not doing PRP, or after Genius microneedling radiofrequency, I will take the TXA and smear it all over the face while everything is open. And that has been a godsend.
Mm-hmm.
What are your thoughts on, so we discussed PRP and microneedling. What are your thoughts about RF microneedling for melasma?
Dicey.
Yeah, I personally think the regular microneedling works better. I think that RF can, and I've been reading a lot of articles about RF microneedling. There are reports where it actually can, if someone has super, super thin skin and not enough dermis, it can actually make things worse. And I think that with melasma, it can make it worse because it is an irritating, intense procedure.
Yeah.
And very inflammatory.
I mean, we love our Genius. That's the one that we have, radiofrequency microneedling,
Deep
right?
inflammation.
Lutronic, but absolutely. I have played with it, but I like my hand. I like my skin pen. I have to say, I like my handheld microneedling. For melasma.
For laxity.
Absolutely. Laxity,
hands down.
tightening, scarring, absolutely. And we love the fact that our needles are insulated, so we can absolutely use it on any skin type, which is, I think, so important in this day and age, you know, to spend, you know, 100 and whatever thousands of dollars on an energy device and then only be able to use it on 3 skin types. No, we don't have that kind of money. And I think it's ridiculous. So we make sure jointly decision that we can use whatever we purchase on everyone.
And I do think that's an excellent point to bring up. When you look at devices, so if we have some younger trainee residents that have joined us, it's not the same as when you're in training and then maybe you're in an academic center and you have all the lasers, all the different things. When you go out into the real world, you want to see the demographic that you're going to be treating and make sure to be able to have, whether it be invasive or non-invasive devices that can treat that patient population that you're going to see. And I always say having colorblind tools is very helpful. Our needling pen is colorblind. Even here in Thailand, all year round, it is so hot here now. I can't even tell you what temperature it is. It's 100 and something. I'm so grateful to be inside, but all year round, I feel safe with my needling. RF needling, not for melasma, but for other indications. Now, we have gone over our time, but our time has flown.
Already?
What?
Yeah, already it's 7:40.
We'll talk about this all night.
I know.
We have so many people that have joined us. I do want to open it up. If there are any last questions that anyone wants to ask, please put them. We'll do our best to answer. And I just want to thank the Lady Derm Docs. You guys have been.
Thank you.
I'd like
and please, we invite the audience to join us on our Instagram, and we can still answer questions from there.
Feel free to DM us.
Perfect. So everyone that's joined us this evening, if you would like to DM at Lady Derm Docs at Houshmand MD, we would like to answer your questions. And who knows, maybe we'll go part 2 of this, because this is one of the topics that so many people want to know. So have you covered use of Derma V laser is one of the questions. And so I will let you guys want to answer that? We didn't answer that, by the way, this for the sender that sent that. So we're happy to address that. Why don't we make that our parting discussion?
Go ahead.
I love my Derma V, but not for melasma.
Yeah.
Sorry, James. He's the one who created it. I love it for redness. I love it for epidermal lesions. But
love it for poikiloderma savant,
acne spots, post-inflammatory hyperpigmentation. But because I find that, I mean, I haven't seen any.
No.
drastic improvement in melasma with the dermatologist.
And because it has a dual wavelength of 532 and a 1064, it enables us to be able to use it on all skin types. But really, the 1064 is the safest and the only one that I would use for skin types. I'd say really 4 on to 7, you know, maybe even 3.5. So you can't do a 532 on somebody who's type 5. You just can't. You wouldn't.
If there's a, sorry.
I wouldn't do it on some type. I really wouldn't. It's one of those where I'd rather maybe a test spot, but I'm not comfortable. I do want to answer this because I do think that it's an interesting question that we address, but not directly. They're asking what are the ages you can get melasma, and I have seen melasma in as young as in 20s. I have not seen it yet in a teenager.
We've seen it in teenagers.
In 20s and above. And again, part of it is genetics, part of it is where they live, lifestyle.
Birth control pills. I mean, yeah, a lot of factors.
Not as common in teenagers, but now that you mention it, I have seen it in some 17 and 18-year-olds. I haven't seen it in 13 or 14. But I have seen it in 17 and 18. Mm-hmm. But I agree with you. I see it much more routinely in women in their 20s now, in their kind of their mid-late 20s. Right. So, yeah, definitely.
Do you think it's from their OCPs predominantly? Their genetic?
I think when they're that young, yes.
Yes.
I would agree. So I want to thank the Lady Derm Doc. I really want to thank ASD.
Thank you.
Thank you for asking us to join you.
Very honored.
Honored to be with you. ASDS Skin MD, I want to thank the ASDS. We have had a wonderful year doing our lives with the true skin experts, sharing our expertise with the community, with other physicians. And I really want to say to those of you that have joined us, do your homework when you're seeking out a medical professional, especially a dermatologist, a board-certified dermatologist. How do you know that we are? Look for the words FAAD. You can go on the ASDS website. You can look up based on your zip code, and you can find wonderful colleagues and wonderful dermatologists that would be happy to see you. Or you can send message to both at Lady Derm Docs and myself, and we guide you as to which direction to go. Because unfortunately, if someone writes, I do want to make this point, if someone writes cosmetic physician, that is a very vague term. Make sure to look for board certified dermatologist with those initials, and don't be embarrassed or bashful to ask questions. Ask us where we trained, many of this procedure you've done. You want to really know, and that's why we called our campaign Own Your Expertise. All of us have spent a very large amount of time training specifically on hair, skin, and who board certified dermatologists are. So I can't stress enough when you all do your homework. And again, thank you so much to everyone that joined us. We're happy to take additional questions. And thank you to ASD letting us use their platform to discuss this very important topic. Have a great evening, everyone. Until next time.
Thank you.
Bye.
Thank you. Bye.